So again, talking about the persistent depressive disorder, which is also called as dysthymia, which is often characterized as milder than MDD, but have more than two depressive symptoms. Because in MDD we were having more than equals to five depressive symptoms. So if you have more than two depressive symptoms lasting for more than equal to 2 years, with any remission lasting in less than 2 months since the past 2 years, then that is called as the persistent depressive disorder. And there is another thing called as MDD with seasonal pattern, which is formerly called as seasonal affective disorder. The major depressive episodes occurring only during a time in particular season, example, winter, most commonly in winter, in more than two consecutive years and in most years across a lifetime. Okay. Now, atypical symptoms are common and treatment is with the standard MDD therapies and light therapy. Now, and we have one more question with us. So, what is the most likely diagnosis for this patient? A 40-year-old man is brought to the emergency department by family members who report a recent change in his behavior. They describe a noticeable decline in his daily functioning, withdrawal from social interactions, and an increased preoccupation with guilt and feelings of worthlessness. So he also mentions hearing voices that berate and criticize him despite no external presence. The patient denies any history of manic or hypomanic episodes. What is the most likely diagnosis in this patient? MDD with psychotic features, schizophrenia, bipolar disorder, generalized anxiety disorder, and substance-induced psychotic disorder. So the presence of major depressive episode with psychotic features, including auditory hallucinations, suggest a major depressive disorder with psychotic features. Now, in this scenario, the psychotic symptoms are occurring within the context of a depressive episode. So the correct answer have become a major depressive disorder with psychotic features. Here we have one more question with us. Which of the following is the most likely diagnosis? A 29-year-old woman comes to the office due to persistent fatigue. The patient has been experiencing daily exhaustion and has no energy to do little things. Her symptoms began 3 years ago after she closed her jewelry making business due to financial problems. The patient used to enjoy creating unique jewelry pieces but has had no interest in making anything since her business closed. She has felt unhappy throughout this time, avoiding friends and social gatherings, and is hopeless that her life will improve. She has had no changes in appetite or sleeping patterns, problems with concentration or suicidal thoughts. Physical examination and lab evaluations are unremarkable. Now, which of the following is the most likely diagnosis? Adjustment disorder with depressed mood, avoidant personality disorder, chronic fatigue syndrome, major depressive disorder, or persistent depressive disorder. So our symptoms are since the last 3 years. So please choose the answer wisely. So what is the differential diagnosis of depressed mood? So major depressive disorder is more than equal to five symptoms for more than 2 weeks. Persistent depressive disorder is when there is depression for more than 2 years with more than two of any of the following: sleep disturbance, appetite disturbance, low energy, low self-esteem, poor concentration, and hopelessness. Adjustment disorder, onset within 3 months of identifiable stressor, marked distress and or functional impairment. So it is when like if you have moved to another city, then you may be having you may be feeling homesickness, or you may be feeling difficulty in adjusting to the environment, and the person may be showing the depressed mood. So that is called as the adjustment disorder. So which if it does not meet the criteria of the DSM-5 of the depression, but there is identifiable stressor, then we label it as adjustment disorder with depressed mood. And the normal stress response is when we just show a normal stress response. For example, if we have a examination coming up, then we may show stress symptoms like we may have decreased appetite, we may have decreased sleep, we may have low energy, or we may have hopelessness. Okay, and that is called as the normal stress response. So for the last 3 years, this patient has had an unrelenting depressed mood, low energy, and feeling of hopelessness. Now, in the absence of additional depressive symptoms, example, change in appetite or sleeping patterns, problems with concentration, her presentation is consistent with a persistent depressive disorder, also known as dysthymia. Now, to diagnose a PDD, any of the following more than two symptoms should be present for a period of more than 2 years. So, poor or excessive appetite, insomnia, low energy, low self-esteem, poor concentration, hopelessness. While there is a significant overlap with major depressive disorder, PDD can be differentiated from major depression by the number of concurrent depressive symptoms. Okay, and more than five depressive symptoms need to be present for 22 weeks to diagnose a major depressive. So it is 2 weeks. Okay, 2 weeks to diagnose major depressive disorder. So what are the neurotransmitters that are involved? Okay, now dopamine is involved in motivation and reward. Okay, mood cognition and learning. Norepinephrine is involved in energy, mood cognition, and anxiety or depression. Okay, and serotonin is involved in appetite, impulsive nature, anxiety, depression, and mood cognition. So for the mood disorders, so dopamine, norepinephrine, and serotonin, all three are somewhat involved in one way or the other. Now, we are generally focused on in the serotonin part, okay? Because the undersupply of serotonin will lead to depression, and some antidepressant drugs are just targeted to the serotonin level. But if we have something like which involves the learning, attention, and emotion, then we also go towards dopamine, okay? Now, oversupply of dopamine will lead to schizophrenia, okay? And undersupply will lead to tremors and decreased mobility in the Parkinson's disease. Okay, now there are other drugs like acetylcholine, norepinephrine, GABA, and glutamate, which are used according to other diseases. Okay, but when we are focused towards the mood disorders, we are generally involved with serotonin. So whenever a person has a major depressive episode, okay, there may be a sleep pattern, different sleep patterns like decreased REM latency and slow wave sleep, increased REM early and total REM sleep, repeated awakenings, and early morning awakening. So have symptoms for more than 2 weeks. It is diagnosed as major depressive disorder. No, so no symptoms may be any of these, okay, more than equals to five, or all of these, like sleep disturbance, interest loss, which is called as anhedonia, guilty, energy loss, concentration loss, appetite or weight loss, psychomotor retardation or agitation, suicidal ideation, and depressed mood. Subtypes are recurrent, two or more episodes with a free interval of 2 months, dysthymia lasting at least 2 years, seasonal affective disorder in winter, improved with light exposure, and atypical, which is one of the most common subtype of depressive disorder. It is when the patient is having hypersomnia, overeating, weight gain, sensitivity to rejection, and treatment we generally do with MAO inhibitors and SSRIs. Now, ECT is reserved if, yeah, if the patient has suicidal thoughts, and we have to acutely treat the patient. So we need to anesthetize the patient, and if the patient is disoriented, or if the patient is so suicidally ideated that we may have to acutely treat the patient, then ECT is the one thing that we do in the beginning. Because all the antidepressive or psychiatric drugs, most of them, they generally take 2 to 3 weeks to act. And in the beginning, some of the manic symptoms may come and the patient may take his life. So we have to go for ECT in some selected patients. Now, when we talk about the major depressive disorder pathogenesis, so genetics, okay, and there is a 10 to 50% risk with first degree relative. Monozygotic twins have 50% of the risk, okay. Now, this information is very, very important regarding the major depressive disorder. And another is the monoamine hypothesis. Whenever there is decreased norepinephrine and serotonin, as supported by the postmortem studies, antidepressant mechanism of action, and PET scans. So whenever there is decreased brain norepinephrine and serotonin, then that may trigger depressive episodes. Or also there is one thing called as a Beck's cognitive model, which is a triad of negative thoughts about oneself, one's world, and one's future, recurrent patterns of depressive thinking, and then that is one of the psychological cause of the major depression. Now, whenever the patient have major depression, there may be some major symptoms, okay, which I've already discussed, like anhedonia, anergia, fatigue, insomnia, feeling of worthlessness, poor cognition, depressed mood, decreased appetite or weight change, okay, or maybe increased appetite or weight change in atypical type, psychomotor agitation, recurrent thoughts of death or suicide. This is some other symptoms like loss of libido, mood varies by time of the day, worse in the winter, or onset in month after delivery, anxiety, hallucinations, and delusions. So now this is on the diagnostic criteria for the major depression. Okay, sometimes we use DSM-5, sometimes we use DSM-4, but it is somewhat the same. So five or more of the four of symptoms, CE caps, the mnemonics, five or more of the symptoms for at least for more than equal to 2 weeks, then we diagnose it as a case of major depression. Now, what are the complications of major depression? Okay, so there are some What are the most common is the recurrent depressive episodes. Okay, even when we treat the patient can again land up into depressive episodes. Okay, another one is the educational underachievement. Okay, which can be due to the difficulty concentrating and in the cognitive impairment of the patient. Okay, now dysregulation of the hypothalamic pituitary adrenocortical axis due to the pathophysiology that is involved in the major depressive disorder can cause high levels of circulating cortisol that causes the placenta during the pregnancy, because cortisol is released when you are in stress. Now in major depressive disorder you are in constant emotional stress. Now that will trigger the release of cortisol. Now high placental cortisol is correlated with the low birth weight, so the complication pregnancy will be low birth weight. There can be other things like coronary artery disease, okay, and social isolation and interpersonal challenges. Substance abuse or dependence is very major complication of major depressive disorder, and the person may have ruminative and worry thought patterns, which can lead to anxiety disorder. So this is how a depression is linked to number of diseases, okay. So even if the patient is having only emotional problems, the patient may show psychological, physical problems if the patient is having recurrent depression or acute major depressive episodes. Okay, generally the patient does not come you with emotional problem or with decreased sleep or with social isolation. They will come you with some physical complaints. Okay, and when you go on looking towards the cause of the physical complaints, and when you treat the physical complaints, then also it is not going off or another physical complaint is coming in, then we need to consult a psychiatrist, and this is how you diagnose. This is how you will approach a case of depressive patient. So the timely referral of the depressive patient is very, very important, because you may think that the patient is having only physical symptoms. The patient is only having a headache. You may give medicine of the headache and send the patient home. But if we do not treat the depression patient in time, then the patient may commit suicide and there will be a loss uh, of the life. Thank you for watching. Keep studying hard.